to where I want to pick up the conversation. So we're not going to go over every slide. Because as Kevin said, some of the earlier part of this in particular was covered in the video that you guys watched. And we will be taking another break sometime around noon. And I will be pausing at that point to, once again, check in with you guys about questions or observations or experience or expertise that you have to share with some of this. And I think that makes us all the richer for it. So I'm going to go ahead and advance the slides here a little bit. Da, 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 da. Okay, so let's see. There's one thing I want to talk about here briefly before we go on. Not every traumatic event results in a lasting problem, and this is an older slide. If I had to write it now, I would probably say it a little differently, and that is all trauma is stress, but not all stress is trauma, right? And so I actually try to be fairly careful when I'm talking about exposure to potentially traumatizing stress, not saying diagnosed with PTSD, because we know that I could take all of you guys in that room and there could be a stressful event that could be potentially traumatizing. And some of you guys would perhaps have some indicators of PTSD afterwards. Some of you would not. Some of you might meet all the criteria for a diagnosis. Some of you wouldn't. So I want to be very clear about that. And I also want to talk about this a little bit briefly, which is what changes something from a stressor to trauma really can be boiled down to the organism, the body, the person's ability to cope with it. So if it's something that's stressful and unpleasant and you didn't like it, but you had some things you could do about it, or you had some ways you could understand it, or you had a great support system around you, you are less likely to identify that as a trauma or later show indications of having PTSD than if you don't have those things. So I think that's just sort of a handy way to think about this. All trauma is stress. Not all stress turns into trauma. And we know that there's some factors. I'll go over these just briefly because there's a different point I wanted to make. And then we'll dig in a little more to what I started talking about in terms of big T trauma and little t trauma. But there are some factors to, let's say, an event that we know can contribute to whether or not people are likely to experience them as a trauma. And they're pretty common sense. How long that lasted, how intense it was, time of day. This is a fun one. When you look at, let's say, somebody getting mugged, if they're mugged in broad daylight versus on a darkened street, they tend to experience the nighttime event as more stressful because they can't orient themselves and see what's going on. Whether there was any warning, whether this was intentional or was preventable, the scope, how many people were affected by this thing. So once again, pretty straightforward. And this last item, I think, is the most important for what we tend to see working with folks with developmental disabilities. And that is your support system during and after a traumatic event. And as we started talking about earlier with the biopsychosocial spiritual model, a lot of the folks we work with, not all of them, but a lot of them are at risk for having very poor support systems. They don't have a lot of people in their lives. They don't have people who are natural supports or some of those soft social contacts. They have people who are paid to be there. And I don't want to underestimate how incredibly important that relationship can be. It's just that most of us don't only have people in our lives that are paid to talk to us. So we know, once again, this is another thing that puts some of our folks at greater risk simply by virtue of having a physical or developmental disability for experiencing a stressor that can then become a trauma. Now, those are sort of the situational factors, and here's some individual factors. And again, these kind of make sense, right? Do you have a history or a family history of mental illness? Are there some inherent factors of resilience and vulnerability? We think now that that might even be genetically linked. There are a couple of gene pairs or like allele pairs that have been identified where if you have two long ones, then you seem to have more emotional resilience. If you have one long and one short, then it's like, if you've got two short ones, you might be more vulnerable to struggling with stress in your life. Not having the stress, but how you can manage it, incorporate it, move on from it, that kind of thing. Substance abuse makes it really hard to do any of this as well. If you are currently numbing your feelings with a substance, then it's hard to process them, all of that. Difficult relationships, poor attachment to others. This is the mirror image of the thing I just talked about, which is when you don't have a lot of people around you, or some of your relationships are toxic, then it makes stress more likely to become something that is unmanageable or overwhelming to you. And that's what turns it from stress into trauma. There's one point I want to make here, and if any of you read my book, you read me go off about this because it's so important, and I feel like it is still so overlooked. And that is how we view what a victim is or who a victim is. We know, for example, that if you take kids who are presenting similarly, that boys are more likely to be diagnosed with the same kind of similar presentations as having a behavioral diagnosis. And I've noticed that this is true in DD. In my earlier presentation, I talked about some of the more common diagnostic categories that we see for people with developmental disabilities. Behavioral diagnoses were right up there. And I'm very conflicted about that. I have a lot of different opinions about that. I think sometimes that's because of, as we were talking about earlier, communication issues. I think that when someone struggles to communicate, it can make them more frustrated, and they may be more vulnerable to kind of demonstrating with their body how they're feeling instead of using their words. But I also think how we feel about people sometimes determines whether or not we give them an emotional diagnosis or a behavioral diagnosis. So back to my point, if you have girls and boys roughly the same age, roughly the same presentation, boys are more likely to be given a diagnosis that's behavioral. Oppositional defiant disorder, which is I don't think that even, it's a bad arrangement of a diagnosis. Oppositional defiant disorder, ADHD, conduct disorder, intermittent explosive disorder, whereas girls are more likely to be diagnosed as depressed or anxious. In other words, and I talk about this in the book, boys are more likely to be seen as bad, and girls are more likely to be seen as sad. And now we also get into racial differences. So we know that young people of color, we see an even bigger result of that young boys of color, young men of color, are far more likely to be given a diagnosis that has a behavioral core, and white kids, white girls, are much more likely to be seen as emotional. So we see one group as vulnerable, and we see another group as dangerous. And as I said, my work was in the teen world. So once we start getting out of that cute little kid age and we get into more that teenager age, and especially for boys who start getting some of that height and body mass, we start seeing them differently, and we start missing vulnerability. And I think this is true in the DD world, and it makes sense as well, right? If I'm working with Kevin, and Kevin can be violent, he's kind of a big dude, and he can't communicate very easily. Sometimes it's hard for me to know what's going on with him. He might be kind of frightening. And that can mean diagnostically that I'm more likely to miss the vulnerability. I'm more likely to see that he's acting out of fear. Fear is vulnerability. If all I see is aggression or anger, and we know that anger actually is a result of fear or hurt, then I'm going to be treating him as a threat, and I'm going to be looking more towards control in terms of my interventions with him. Whereas if I can see him as vulnerable, then it's easier for me to really get to probably a more accurate understanding of what's actually going on when we're talking about trauma. So, and I use this slide because, as I say in my book, a previous history of trauma, stressors, or abuse. I worked with a lot of kids who came from pretty tough neighborhoods. A lot of them were gang involved. And when they would report an event that had happened to them that we would normally look at as potentially traumatizing, they'd had a really severe loss or something really terrible had happened. What I observed was that we were more likely to see that kid and go, oh, he's a survivor. Oh, he's a tough kid, blah, blah, blah. And what we actually know, and this is where this slide comes in, is that a previous history of trauma, especially when it's been unidentified, untreated, unsupported, makes that kid more vulnerable to the stress that's just happened, not less. He may have a tough exterior, but he's more vulnerable, and there's more potential damage that can be going on. So this really does start to become pretty relevant to how we see people who we are either diagnosing or who have been diagnosed by someone else. I often talk to audiences where no one in that audience is going to be diagnosing anyone. So they just get the diagnoses, they're in someone's chart. And if, especially if you work in the adult community, if you get somebody who's been around, who's maybe been kind of challenging, and they've been to different counties and different providers and different things, they can have a list of diagnoses a mile long. Like it's impossible to imagine one human being can have all of these disorders. And so I think that we, in those situations, we get these diagnoses and these labels that have been given to people, and we don't question them. And if we're more aware of the bias that can be present in the diagnostic process, because even when we're trying to do a good job, those of us who are diagnosing someone, we're humans, we're people, we have our biases, we may not be aware of them, we should be, and our field needs to get better at this. It's just important that whether you're the person making the assessment and doing the diagnosis, or you've been given it from someone else, to be aware of these biases and these problems in the mental health world in terms of how we are viewing people and who gets to be injured and who is dangerous. Okay, so uh, we talked about, I think I actually want to go back a little bit. Let me talk about a major trauma. So this is the stuff that's pretty common sense. Again, if I say PTSD to you, this is probably what you think about. These are devastating events. And as I said earlier, for things like complex PTSD, it could be a series of events or an ongoing toxic situation that someone is in. But a simple way to think about major trauma, or as we'll call it, big T trauma, is that it only has to happen to you once for it to potentially be life disrupting. So a sexual assault, a physical assault, verbal or physical, or verbal or emotional abuse or manipulation, combat PTSD, being in war or being a civilian in war, natural or man-made disasters, invasive medical procedures or catastrophic illness, traumatic grief, whether the loss itself occurred during a traumatic event, like a violent event, or something like the loss of a child, where the loss itself is so devastating that it creates its own form of trauma. Humiliation, bullying, deprivation, and powerlessness to act on one's own behalf, captivity. We know that, for example, people who are kept in solitary confinement in prison show signs of really, really bad trauma as a result of that. So some of these may seem very far away from the lives that some of our individuals live. Some of them are. But I would point out something that sounds very different, like deprivation and powerlessness to act on one's own behalf, and think about people who live in a locked hospital ward or who live in a developmental center where they can't leave. I'm not saying those things are bad or that they shouldn't be there. I'm just saying that some of these things that may look farther away from our folks perhaps are not as far away as we think. So these are sort of the big T traumas. And as I said, we know that they are worse when they happen early in life. I would say any time in childhood, but 0 to 7 and particularly 0 to 3, because that is when the brain is still wiring itself in. There is a lot of wiring and development that happens after birth. And the age of 0 to 2 is really critical. So things that happen early in life, things that are really severe, and things that happen repeatedly or chronically. Those are sort of the trifecta of complex PTSD. Whereas if I experience one of these events and I had a pretty secure childhood and I've got some pretty robust resilience and I've got a good support system around me, I may still develop PTSD from this event, but my prognosis for that and my responsiveness to treatment is probably better, and a bit easier. This is something that Vanderkolk has talked about, that when you have a solid base to build from, trauma is typically going to get a better prognosis in terms of treatment. Whereas when you don't have that, and we're looking at that potentially complex PTSD, it's harder. That's not to say that people don't heal. They absolutely do. It's just harder. And we're probably going to need to use lots of different modalities to do that. So that's big T trauma. And then we talked about this stuff. Okay, now we're going to talk about everyday stresses. And again, working with folks on the autism spectrum, I think really brings this home of how stressful it can be to spend your life in a body that doesn't filter sensory input very well. spending your time being distressed about how your stomach is feeling after eating food, or the itchiness of your shirt, or a light that's buzzing, can be incredibly stressful. And so now we're looking at this small thing, but that something that builds up over time. And so we're going to talk about some of these things. And I sometimes call this ordinary life trauma. Feeling different, not being accepted, not being able to do what other people can do, moving to a new home or having a significant change about where you live, knowing that you're different than other people somehow, not being listened to, being misunderstood, failing at a task, getting confused and overwhelmed. Um, I would add things like daily microaggressions and oppression from racism, homophobia, transphobia, sexism, ageism, all of that stuff. Um, you can sort of look at this list, and especially for the things on this slide, and go, well, I've experienced all of those things or most of those things. In fact, since I can see you guys all on camera, raise your hand if you've never, ever in your entire life experienced anything on this slide or anything that I mentioned. Everything's been absolutely peachy every single day of your life. Yep, nope, that's nobody, right? In fact, I usually joke that I could have labeled this slide seventh grade. You know, like this is the stuff that happens to everybody periodically. And so, if it's so universal, why are we calling it a trauma? And I've already sort of given the answer away, and that is that it's not about the severity of the event, like, um, the horrible events we're seeing play out in Texas with the flooding. That is a once in a lifetime, life disrupting, horrible event. This stuff maybe is much smaller, but it's about two things. One is the repetition of it. So I used to say, imagine being in seventh grade for your whole life, but I stopped saying that because it's too traumatizing to everybody. So, but just imagine this thing that goes on over and over and over and over and over. And when I talk with different audiences in the DD world, we have this wonderful thing that's happened, which is that people now live much longer than they used to decades ago, depending on what kind of like medical condition or syndrome they have. It used to be decades and decades ago that a lot of people didn't make it out of their 20s. But now, because we have better medical treatment, people can live much more normal lifespans, which is wonderful. But if that person is in a environment that isn't like terribly supportive, or if they aren't feeling empowered and recognized and valued, well, now we're taking these feelings, that seventh grade feeling, and now it's day after day, month after month, year after year, decade after decade, on and on and on. And what we see when we do brain imaging is that when trauma has been early and severe, you can actually see some changes in the brain. There are some parts of the brain, like the cortex, that are a little bit smaller than they should be because they're not being activated as much. And there are some parts of the brain, like the middle and the bottom of the brain, where the emergency systems are, that are bigger than they should be because they're being activated too much. And what we see with little t trauma is that given enough time and enough repetition, you can start to see some subtle versions of those same changes. In other words, it's kind of like smashing a rock with a hammer or dropping water on it. It takes a lot longer, but eventually that water is going to break down the rock just like the hammer did. So this is really a different kind of trauma. The other thing that makes it trauma isn't just the frequency, but the lack of resources. So I want you guys to think about a time that you failed in your life. And I'm not going to ask you to share it or write it down or anything like that, but just think about it. And I want it to be kind of a big failure. Okay. It wasn't something small like you lost the family Monopoly tournament, but something big, something you cared about, something you tried at or that was important to you and you failed. Maybe other people saw you fail at it. My mom was taking her driver's test and hit a parked car, and it was a police car. So that's a pretty good example of like a pretty big visible failure. Um, but I want you to think about that, and I want you to see if you can remember how it felt. It felt pretty crappy, right? It does not feel good to us to fail. And I always tell audiences I choose that one because I know something about you guys. I know your agency a little bit because we've been working with you, and I've had the pleasure of getting to talk with some of you guys. But I already knew some things about you before the first time I met you. And one of the things I knew is that you guys, as a group, are really good at not failing. And the reason I know that is because you have difficult jobs that you had to get training for and that are difficult to do. They're highly responsible. So what happens when someone like that fails, typically, is a couple of things. Number one, hopefully you have people around you to pick you back up and dust you off and go, that's all right, you'll get them next time, Tiger, right? You've got someone in your life, hopefully lots of people, but at least that one person who believes in you and thinks you're the bee's knees and encourages you and you can get it next time, right? The other thing that you have is resources to turn it into a success. Now, that could be a couple of different things. It might mean that you just, study harder for that exam and then you pass it the next time. Or you decide, yeah, maybe accounting isn't for me. I'm going to go into human services because that's where my gifts are. Whatever it is, you found a way to turn that into something different. Now ask yourself, as we've been talking about throughout the morning, how many of those resources do some individuals with developmental disabilities have? Some of them have supportive people around them. Many of them don't. Very often they may be in a situation where they can't leave or change it. They can't leave the work setting or the day treatment program or the whatever. They're kind of stuck there. And they may not have some of the skills and resources needed to turn this failure into a success. I watched this over and over and over with the teenagers that I worked with who had severe emotional disturbances. I think that's the code that we used. And typical classrooms were a nightmare for them. They failed in every way possible, spectacularly. Socially, they bugged every other kid. They couldn't follow what was going on. They bugged the teacher. They felt like huge failures every single day. And so when we start looking at this form of trauma for people with a disability, we really have to see how pervasive it is and how often, until they get into that supportive environment or they get that person who's going to encourage them or whatever, they don't have a way to transform it into something else. So, as I started talking about a little bit earlier, when we talk about what is the rate of trauma in our community, we know that the exposure to potentially traumatizing stress is somewhere possibly above 90%. And we get that number when we put those two things together. The higher rates of big T trauma, which we already know any kind of disability leaves you vulnerable to, and that little t trauma. And this is my favorite quote about this. A friend of mine is now a retired lieutenant in the Ohio Highway Patrol, and he works a lot with trauma in first responders and law enforcement. And this is how he explains it to them. He says, big T is like being attacked by a bear, and little t is like being attacked by ducks. And I love this because one duck, every now and then you can probably deal with, not a goose. Geese are terrifying. But if it's just the occasional duck, you can probably handle it. But when it's hundreds of ducks for a long time, that damage is going to start to look like a bear attack, right? So this for me is a handy way to remember this. And it's most important that we remember that our folks have both. They've got bears and ducks all over the place. Okay, so we're going to move through some of this material a little bit more quickly, but I do think that this is important when we talk about working with any kind of younger population. I mentioned earlier connection as an example of one of those universal human needs. How we want that connection to be, what we tolerate, we're skilled at, those can be different. But the need for connection is universal throughout the lifespan. So for young children, anything that threatens connection with the people that should be nurturing to them, such as mental illness or trauma or something going on in the caregiver, that is potentially traumatizing. And I want to make a quick point here. Sometimes when people talk about trauma, they'll say, oh, it happened before they could remember it, so it didn't, it's not a trauma. We tend to think that trauma is about the story. Knowing the story of what happened can be helpful in some forms of treating trauma, but you can imagine an infant or a very young child who is being terrified or neglected or hurt, and their nervous system is wiring them for that kind of fear. Having a memory of the story consciously has nothing to do with it. So it's very important to not let people tell you that or to get confused by that. Having a memory of the event does not mean what people think it means. For teens, any kind of social connection that's threatened is potentially traumatizing. We are seeing, as I'm sure you guys know, record numbers of suicidality, depression, and anxiety in teenagers. And we're still kind of debating the cause, but there are multiple causes. We're trying to figure out what they are. But there's really no debate that the access to constant social media and social messaging and social pressure is absolutely a major factor in this. So feeling accepted or not feeling accepted, feeling like you're measuring up or not feeling like you're measuring up. For adults, we can kind of handle that, but for teenagers, they really can't. And then when we get into things like bullying, incredibly traumatizing potentially. For adults, that threat to connection could sometimes be something like loss. And that gets into what I said earlier, that if I lose someone really important to me, we may not necessarily look at me and think that I'm experiencing trauma, but we know that people with a traumatic loss will qualify for a diagnosis of PTSD sometimes. And when you treat that, as I do in my practice, you've got to treat them separately. You've got to treat the trauma and then you treat the grief. So this is really just another way of reminding us that connection really is at the heart of so much about how human beings function. Okay, going to zoom on ahead here a little bit. I'm going to review these briefly. Again, I think if you're somebody who's doing diagnosing, these are familiar to you. But if you don't do a lot of that, then this is helpful just so you know when someone has a diagnosis of PTSD, what's involved with that. And there are a few other criteria like duration of symptoms and things like that. But generally speaking, when people think about that diagnosis, they're looking at meeting a certain number of symptoms in each one of these four categories. Hypervigilance, you're always on red alert. And we tend to see that in people with developmental disabilities very physically. So they startle, they have an exaggerated startle response. They are irritable, they're pacing a lot, they're rocking a lot, they're gritting their teeth a lot. I often think that we could find some interesting parallels with incidences of trauma and toxic stress and dental issues like TMJ or tooth grinding. They can be more combative, more aggressive because they're really tense all the time. It does a number on sleep, right? And as we see, these things all sort of swirl in together. So when we talk about the biopsychosocial spiritual model, emphasizing sleep may be a way that we kind of find a way into supporting someone's trauma, even if we haven't identified that that's what's going on with them. Avoidance. What's interesting about this one that people don't always necessarily think about is that it's pretty obvious that people would avoid something that's sort of a one-to-one trigger, right? So I was talking this morning about if I've experienced trauma from somebody with dark hair and glasses, then Kevin comes to work with me, and maybe there are those two little bits of information that my amygdala grabs onto, and now I'm swinging my fist at him. What we don't always understand about avoidance is that it tends to ripple out and it tends to get to be more generalized. So it might start with guys with dark hair and glasses, and then it may ripple out to just men in general, or tall women, or anybody getting too close to me. You can see this with veterans sometimes. If a veteran said to you, yeah, I was in active combat, and so I don't go to fireworks displays, you'd be like, yep, that makes sense. Good idea. But then what can happen, especially when the trauma is untreated and when avoidance is the only coping strategy, they start needing to avoid more and more things because more and more things trigger them far beyond whatever the original cause was. So that veteran starts by, yeah, I don't go to the fireworks. And then it's like, well, I don't go to, where there are large crowds of people. And I don't go to the shopping malls and I don't go to the store when it's crowded. And I don't leave my house when it's light. I've often thought that if you go to Walmart at 4 in the morning, some of the folks you see there are there because of avoidance and PTSD. So it's important to keep in mind that avoidance isn't just tightly locked into a very specific trigger from a specific trauma. It can start impacting everything. And again, looking at something like the intersection of trauma and autism, if I'm already tending to avoid or shy away from things because it's sensorily overwhelming to me, and I've got unrecognized trauma, and I'm increasingly avoiding things I can start being really shut down, and I can also start being really rigid. So if I avoid things because they are potentially triggering, and I've got a pretty narrow little lane that I need to stay in to avoid being triggered, and then something happens that knocks me out of that, something unexpected, and I blow up, it's easy to see that as a behavioral problem or rigidity and not seeing the true root of it, which might be avoidance from PTSD. Intrusion, everybody's pretty clear about this. Upsetting memories, intrusive thoughts, nightmares, flashbacks. I don't know why flashbacks aren't up there. Um, this is the stuff most people know about. And I will tell you, interestingly, that this is the one area where we have a symptom specific to PTSD that is treatable with medication. There are some individuals who respond well, not everyone in my experience, it's kind of hit or miss, but there's a medication called prazosin, which lowers blood pressure, and that seems to help people who are having nightmares not have nightmares. So it's one of the few things about trauma that we can really directly treat medically. So, negative alterations in cognition and mood just means the way you feel and the way you see the world gets messed up. If you think that you're bad and everybody's dangerous and the world is out to get you, and it leaves you more vulnerable to anxiety and depression, which makes sense. Okay, so I already talked through these, so we're not going to spend a lot of time there. This is so important that I always make sure to make time for this. Again, I feel like that you guys, as we've had a chance to work with you and talk with you, I think you have a good handle on this, but it's so easy to forget, even when you've been doing this for decades, that I always want to highlight it. When you are limited in how you communicate, you will communicate in different ways. And we can think of this in a couple of different ways. One can be the big visible stuff like I'm yelling, I'm screaming, I'm throwing my arms around, or I'm huddled in the corner. I'm showing you with my body what's going on with me mentally or emotionally. In the kid world, and I worked a lot in schools, people would use the word acting out, which drives me crazy because it's already sort of annoyed. You know, you can just hear it. Oh, they're acting out. I used to encourage my staff to put the word it in the middle and say they are acting it out, which sounds a little different, doesn't it? Now I'm saying, well, Kevin is acting it out for you. He's showing you, he's demonstrating to you what's going on inside him. So I think we hear it a little differently. And then, of course, there are things that are even more low level. And this is where we see things like unexplained pain or other nonverbal signs of distress like tooth grinding, head banging, things like that. And this is where, once again, that biopsychosocial model is so important because it's really important that a skilled doctor or nurse or medical team is really looking closely, and it can take some time to sort out, is this person having pain because they have a sinus infection and they're banging their head? Are they doing this because they're in emotional distress? It is not easy, and sometimes it takes a whole team of people, a whole village, to sort out what might be going on when there's less or no verbal language. So we have to be constantly very, very sensitive and sophisticated in how we're looking at people. Okay, so going to talk about hypo and hyperarousal. Did I say that right? Hyper and hypoarousal. Yeah. Okay. And in order to do this, I'm going to use this fun little graphic here. So when you think about how your nervous system and my nervous system and everybody's nervous system works, all the way down to little invertebrate animals, we all have basically the same way of being in the world. Our bodies and brains are constantly looking around going, is everything cool? Yeah, looks good. All right. And then we're in that middle band that's white on my screen, might be a little buff or something on yours. And it's sometimes called the window of tolerance or the window of accommodation. And that just is a fancy way of saying all systems go. There is nothing happening in your environment that is making your body feel like it's in danger. All right. So hopefully that's how you guys all are right now. Everything's cool. Temperature's fine. There are no scary noises going on. Nothing's happening. Everything's great. And that means then that your nervous system is kind of at its normal setting. So your blood pressure, your heart rate, your respiration rates, all good. And it also means that the regions of your brain are all kind of communicating and they're all synced up at the same time. In order to talk about this, we're going to do the little hand brain exercise that I love. So take your hand like this. Yeah, I'm going to watch you guys do it. There we go. So, and then cross your thumb across your palm and lightly wrap your fingers down. This is in some ways a slightly outdated way of talking about the brain, but that's only for like cutting edge neuroscience. For our purposes, it still works fine. When you look at your hand here, this is a pretty decent representation of the major regions of the brain. So you've got the bottom, let's say the heel of your palm and where your wrist connects to your arm. And this is a pretty good representation of the bottom of your brain and the brain stem, that little cauliflower stalk at the bottom. And this part of the brain is sometimes referred to as the diencephalon. If it includes parts of the limbic system, you don't need to worry about that. We're going to basically call this region the brainstem, okay? And as you're probably already familiar, either from trauma training or even just watching a medical TV show, the brainstem is where all the basic functioning of the body takes place. If there's no activity in the brainstem, you are dead. In fact, and I talked about this in the book, a little fun fact, the guillotine was considered to be a really modern, humane way of executing people because it instantly severed the brainstem from the body and death happened nearly instantaneously. Fun. So basically, whatever's going on in the brainstem is all the automatic stuff that you don't have to think about right now. None of you are sitting there thinking about regulating your temperature so that your organs don't cook. None of you are thinking about digesting your food or creating the waste that you're going to have to get rid of later. None of you are thinking about remembering to breathe in and out or maintain a consistent blood pressure. Your brainstem is doing all of that for you. And when I talked about kind of how the brain develops at different stages after we're born, when we're infants, the brainstem is pretty much wired in. It's got a little bit to do still, like babies sometimes have to be a little bit more bundled up if their temperature regulation isn't quite right. But basically, that brainstem is up and running and ready to go. Otherwise, you don't have a viable live birth. So that makes sense. And then when you look at your hand brain again, and you go to your thumb kind of in the middle of your fist there, that's a reasonable representation of your limbic system. And the limbic system, again, as you guys are familiar with, is where lots of things happen. It's kind of in this middle part of the brain, and I often think of it as like a connecting station and a way station for all the stuff that's going on in the brain. So there are lots of different subregions of the limbic system, but it includes things like the hippocampus, which involves our conscious and what we sometimes call explicit memories. If I asked you the name of your 8th grade science teacher, you could probably rummage around in your hippocampus and give me that information. Then there's the amygdala, which is what we spend a lot of time talking about when we talk about trauma. So if you look at your thumbnail and you imagine 2 little almond-shaped freckles at the bottom corners of your thumbnail, that's roughly where the amygdala is in your brain, okay? And the amygdala is sort of like the smoke detector of the brain. The amygdala is constantly taking in information through your outer senses. Those are sometimes called the distal senses. And even information from inside your body. Is your stomach tight? Is your heart calm? Is your breathing rapid or slow? It's taking all of that information and it's asking one question. Am I safe? All the time. That's all it's doing. And most of the time, when we're in that window of tolerance and our environment is okie dokie, then the amygdala is answering the question, am I safe? Yes. Now we're going to talk about the last section of the brain, and then we're going to talk about hyper and hypoarousal. So one last time, look at your hand brain and look at the back of your hand and your fingers coming down to your fingernails in the front. That's actually a pretty good representation of the cortex. Which again has actual lots of subcortices, but generally speaking, we just call it the cortex. And it's kind of this thin layer of cells that fits sort of like a swimming cap, like that whole region on the sides and the back and down to the front of your brain. And this is the last part of your brain to fully wire in and develop in a human. So the brainstem at birth is pretty much ready to go. The limbic system, depending on what part you're talking about, is starting to recognizably develop around 6 to 8 months before we're born, and then continues sort of wiring in up until somewhere around age 2 or so, okay? And then, as many of you probably know, especially if you work with or have captive teenagers at home, then you know that this thinking part of the brain takes much longer. In fact, we know that there are some regions of the cortex, especially involving things like impulse control, that take until about age 25, which is why your teen years and your late 20 years usually look pretty different. So this is the three major regions of the brain. And when I say wired in, what I really mean is these neural networks, these kind of like wires in a building that go up and down, back and front, side to side, and let every region communicate with each other. So when you're in your window of tolerance, all the different regions of your brain, back to front, up and down, side to side, the brainstem, the limbic system, the cortex, they're all online. They're all talking to each other. And an example I think I use in the book, and I think it's a pretty intuitive one, is a car. The wheels and the engine and the controls on the dashboard and your signals and all of those things are all working together and talking together, which is really important. If you suddenly can't control the wheels of the car, or none of your monitors work and you don't know how fast you're going or whatever, when things stop talking to each other, that's when we have problems. And that's what happens in the brain and the nervous system when we go into hyper or hypoarousal. So this is how life usually looks for most of us most of the time. We spend most of our time here in our window of tolerance. But let's say during this training right now, there was a fire drill that they forgot to tell you was going to happen, and it happens right now. So the main lights go out, the emergency lights come on, there's that huge, terrible alarm sound, and you did not know this was coming. Well, what's going to happen? If you're like me, I hate fire drills. Even when I know they're coming, they really startle me, which is what they're supposed to do. So if you're like me, your heart's going to start beating faster and you're going to be like, whoa, you're probably going to really jump, and you're going to start looking around about, what am I supposed to do? What should I do? And this is all the stuff that is supposed to happen to keep you safe. Organisms from the tiniest little slug up to human beings have some crude version of this. Let's use slugs as an example. I've never done this before, but let's try it. It's going to be fun. So if a slug is just kind of living its little slug life, slug life, if your slug is living its little slug life, and then it hits like some salt, what do slugs do? They withdraw from it, right? Because that's not the environment that they can be in. So that's sort of like expanding around into the environment or contracting. Okay, that's a version of this. When they're in their window of tolerance, everything's cool. When suddenly their environment isn't hospitable, they're going to react. So we have been built to do this over millions and millions of years. So we go into hyperarousal and we're like, ugh, and then we look around and then we're like, oh, it's just a fire drill. Okay, we've got to gather all our stuff up. If you're like me, even when I knew it was a drill and I was standing outside with everybody or whatever, it still took a while for my heart to calm down, just because it jolted my nervous system, which again is what it's meant to do. But then I come back down and I go through the rest of my day and I'm probably not thinking about it. I might not even remember to mention it at dinner if someone asks me about my day. So my system knows how to go up into hyper arousal and deal with whatever is going on and then come back down. When we are in a state of hyper arousal, what has happened is that there is some information, like the loud noise of the fire alarm, that signals our amygdala, am I safe? No. And so the amygdala starts a sequence. It includes the HPA axis. We won't get into all of that. But basically, it triggers a cascade of reactions. It hyperactivates the middle and the bottom of the brain, which makes sense because your body might need to do some stuff. But while this is happening, if we could do an fMRI of your brain while you're in this fire drill, what we would see is that while the middle and the bottom regions are extra lit up, the top part is going to be less active. And again, from a survival standpoint, that makes a lot of sense. If I'm running away from a bear, I don't need to be thinking about, what kind of bear is that? Is that, if we, like, if I'm busy thinking about all of that stuff, I'm dead. The bear's already got me. So all I need to be able to do is go bear, not bear, run. That's all I need to do. So that functioning at the top part of my brain really isn't necessary. And our brains are ruthlessly efficient. It will divert resources to where the problem is and what the brain needs to be focusing on. And that leaves this stuff relatively offline. Okay? So that's what we mean when we say hyperarousal. The nervous system has gone into this survival protocol. When this happens in the brain starts releasing a lot of norepinephrine and no, yes, norepinephrine and cortisol, which we'll talk about in a minute. This triggers and signals the release of cortisol throughout the body. You've got a lot of cortisol floating around your body at any given moment. And it signals the adrenal glands on top of your kidneys to start pumping out adrenaline. So I've been in a couple of like minor car accidents and things, and they were scary. And afterwards, I remember in one of them, I got out of my car, and people thought I was injured because I was wobbling. I couldn't stand up straight for a few minutes. I hadn't been injured, thank God. But my muscle fibers were twitching out of control, out of sequence, because there was so much adrenaline flooding them. So for a few seconds, I couldn't really control my legs. That's what happens when we're shaking, when we're really scared, is we're being flooded with adrenaline and cortisol. Okay, so about 2/3 of the population, when they're presented with a threat, will go into hyperarousal. About a third of the population, I'm not sure we really know why, will go into hypoarousal. And hypoarousal is the other side of the same coin. It's a survival mechanism, and we usually go into it when we can't get away from what's going on. In the next slides, I'm going to talk about the 4 Fs. You're already familiar with 2 of them, fight or flight. And when we go into fight or flight, we are mobilizing for safety. We're going to do something to get safe. And so we're flooded with all these stress chemicals, and our muscle fibers are twitching, and blood's being directed to our major muscle groups, and we're ready to go, go, go. But what if we can't get away? Or what if the threat is so overwhelming, the tiger pounces on me? Hyperarousal isn't going to do very much for me. So I may go into hypoarousal. And that's like when the power's cut. So imagine hyperarousal is like your building if there's a fire alarm. There are lights flashing, there are sirens going off, you can hear trucks coming down the road, everything's lit up and happening. Hypoarousal is if all the building's power has been cut and the utilities have been turned off and the doors are locked. So it's dark, it's cold, it's quiet, and nothing is happening. Another way to think about these two states and how they relate to survival is hyperarousal is when the tiger is chasing you, and hypoarousal is when the tiger lives at your house. Imagine if there was a tiger in your house. How would you behave? You'd be very quiet, and you wouldn't move around very much, and you would try not to need anything, and your body might get very heavy and slow, and you might even sort of curl up into a little ball. That's hypoarousal. It's your nervous system essentially shutting down. So I'm going to, let me go through a little bit more about how the brain deals with these two states, and then we'll break down what's happening in these two different states. So as I said, this first slide is an example of how hopefully most of us get to live our lives most of the time. Generally, our environments are safe and supportive. Generally, our amygdalas are asking the question, am I safe? And answering it, yep, we're fine. And you only dip into these states very occasionally. Like if you're driving and there's a near miss and you're like, whoa, and you've got to get out of the way of another car, you probably will jump up into hyperarousal for a little bit and be like, whew. And then you get back on the road and you get to work and you probably kind of forget about it. But the bad news about trauma, which later we'll see is also the good news, but right now the bad news about trauma is that your brain gets really good at whatever you ask it to do a lot of. So that's great if you're trying to learn how to play the piano or learn a computer program or learn a language or whatever. You practice, 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 and the more you do it, the quicker and faster your brain gets at doing it. Your brain actually will reroute the connections between your neurons to make little superhighways so that if you are, let's say, practicing an instrument. Did any of you guys learn an instrument when you were kids? Anybody play any kind of instruments? So some of you guys did, yeah, okay. You know that like if you started playing the piano, you had to like look at the music and look at the keys and look at your fingers and blah, blah, blah. And your teacher told you not to do that because over time, your brain will make a shortcut and it will see a little dot on a piece of paper and know where your hand has to be. And you don't have to look at it. That's an example of these little super highways, these shortcuts of these neural pathways that get created when we do a lot of something. Did any of you play an instrument, but now you don't play it anymore? Just somebody like raise their hand or something. Has anybody had that experience? You learned? Oh, some of you did. Great. Okay. So you know, when you were practicing a lot, how whenever you stopped practicing, you were probably at the top of however good you were, right? You'd practice a lot, you were taking lessons, that was as good as you were going to be. And then if you stopped and you stopped practicing, are you still as good at it today if you picked up that instrument than you were when you were practicing? Nope. I don't know about you guys. I used to play the harp when I was a kid. If I picked up a harp now, I'd be like, ugh. And we refer to that as getting rusty. And that's actually a weirdly good analogy because what actually happens is when you stop lighting up those little shortcuts in your brain, those little superhighways, they actually deteriorate. And so you don't have them anymore. And it's almost like you have to go back to the beginning and go, okay, there's the note, there's my finger, here's what I need to do. Some of it will still be there. Probably it won't go all the way back to zero, and you might be able to brush up your skills pretty quickly, but it's not the same. Your brain is constantly shifting and trying to figure out what you're doing and how to help you do that. So if you consistently do it a lot, you're going to be good at it. It's going to happen quicker and more powerfully. If you don't do it so much, it's going to be slower and more sluggish to happen. So again, good news if you're practicing playing the piano. Bad news if your brain is going through this cycle of hyper and hypoarousal. In other words, you're freaking out and then you shut down and then you're kind of coming back to normal, but this happens over and over and over again. If this is happening in your life a lot, your brain looks more like this. It's easier to get into hyper or hypoarousal where you're freaking out or you're shut down and numb and checked out. And it's easier to go up there and it's longer to get back out and you spend less time in that okay zone. And for some of the folks we work with where daily life is triggering or brings up some form of little t trauma, life looks more like this. And one of my favorite quotes from Bruce Perry, it talks about the state becomes the trait. And we especially see this in children, which is his specialty, where if you've got a kid who spends a lot of their time hyper aroused, so they're freaking out, they're combative, they're running away, they're, blah, or they're hypo aroused, they're shut down, they're tired, they're drowsy, they're just like the tiger lives at their house, then we start to think that's who they are. Or we diagnose them purely based on this arousal pattern. So we diagnose them as oppositional when really they're in hyperaroused state much of the time. Or we diagnose them as depressed and apathetic when really they're shut down in hypoarousal. The state becomes a trait. And given enough time, we see people well into adulthood who think this is just how they are, or this is just how the world is, which takes us all the way back to that lovely quote from Pierre Janet when he talks about it's a disease of not being able to be here. When you are spending most of your time in one of these survival brain states, you're not really here where everyone else is. Okay, so I've already talked about this. We don't have time for that. This is another way of, I want to actually come back to this. Did I not include that slide? I guess I did take it out and I don't know why. Okay, hang on. I need to go back to this. Okay, so in this slide, we talk about the 4 Fs, and I used to have a slide that I took out for some reason that explained in more detail what they are. So let me talk about this, and I love this. This is a handout that I use with my therapy clients. It's adapted from the work of Deb Dana, who works a lot with Stephen Porges in polyvagal theory. Do any of you guys do any polyvagal work or familiar with polyvagal theory for trauma? Okay, well, this probably won't get to it today. That could be a training for another day. So anyway, what I want you to pay attention to right now is that band in the middle where it talks about hyperarousal. Hyperarousal, as we've already seen, is that kind of red zone. And we've talked about it being mobilizing you for safety. You're flooded with adrenaline and cortisol and you're ready to go, go, go. The 4 Fs actually refer to different forms of mobilization for safety. The first one we already know, fight. Second one we already know, flight. Fight or flight, we're all familiar with that. The third one you may be less familiar with, although I hear more about it now, and that is freeze. Now this one's a little confusing, which is why I always like to go through this, because it looks like stillness. And you're like, but Laura, you just said we're immobilized. Yeah, you're still for the moment until you can run. So there was a deer in my backyard last night, And she and I were just staring at each other for a while, and she was frozen. But I knew that she was very stressed by the fact that there was this human close to her. She was watching me very carefully to see if I was going to be a threat. And then when I took another step, or I can't remember what I did, she bolted over the fence. So, yes, she was still, but she clearly was ready to go. And so she's still in that hyper arousal state of quick reactivity to get out of whatever the dangerous situation is. So, freeze is a reaction that we may have, but we're still in that hyper aroused, hyper activated state. Okay. Paralysis is another good word for it. And then the fourth F, we're going to stay with the deer theme. This is handy, is fawn. And not in the sense of a baby deer, but fawning is moving closer to the threat to neutralize it. So a lot of us, if we've experienced trauma, it's typically not a mind cave in or something like that. Often trauma is from another person, right? We've been exposed to someone who's been dangerous or harmful or scary or whatever. And so many of us may have learned to try to neutralize the threat by moving closer to it. We see this a lot in instances of childhood trauma or in abusive relationships. So if somebody looks angry or upset, our reflex is to try to calm them down so that we can feel safe. It looks like we're focused on them. Really, we're focusing on ourselves. So fawning can look like appeasement, flattery, being placating or kind of, just going along or humoring them. It can be smiling. Sometimes people can be very distressed if they found that they were smiling or laughing in the face of a threat or someone who is being threatening. And we talk about how that is often a nervous reaction and a form of fawning. They may become flirtatious or sexual. And once again, that has nothing to do with sexuality and has everything to do with trying to feel safe. So whatever it is that someone is doing to fawn, this is still a fear reaction. We can see this in both male and female identifying people. Women are already kind of socialized to do this. So we tend to see it more in women and female identifying people. But that does not mean that it can't happen for men as well. It's just depending on where our nervous system decides to go. And then at the bottom here, we're talking about hypoarousal. And here we talk about collapse, which I've already sort of described to you. And in this case, let's use another prey animal. Deer's kind of big, so let's say a rabbit. So you can imagine a rabbit that's being chased by a wolf, and it's very much in its four Fs, right? It's running away, or maybe it's freezing, trying to hide so the wolf doesn't see it. Now imagine that the wolf catches it. What does the rabbit do? The rabbit might struggle, but let's say the wolf has really got it. Then what you're probably going to see is the rabbit go limp. This is what prey animals have a reflex to do. It might trick the predator into dropping them, or they're about to have a very unpleasant end and they don't want to be around for it. So they kind of check out, almost like leaving their body. And that makes sense. And when we see people in this hypoarousal state, it's not rigid stillness like freeze, it's like checked out, or they go kind of limp. You'll see sometimes people kind of collapse in on themselves. They also dissociate. This is a word we use a lot. When people hear the word dissociating, sometimes they have the most extreme idea of it, like I lose time and I wake up days later in a different city and I don't know how I got there. And there certainly are very, very extreme forms of dissociation like this. Dissociative personality disorder, what we used to call multiple personality disorder, is at the very far end of that continuum of dissociating. But most of us don't do that. And we can think about dissociating in a very simple way. Two things that are usually connected or associated are now disconnected or dissociated. That's really all it means. So we can go into really subtle versions of this. Like if you're driving a route that you take to and from work every day, and you're thinking about the amazing training you were in, or whatever, what you're going to make for dinner, you can suddenly look up and realize that you've been driving without paying attention for quite a long time. Your brain kind of goes on to automatic, and you're just sort of doing these things without being consciously aware of it. That's a very subtle form of dissociation. Another one that we tend to see in trauma, and I think this is especially relevant for developmental disabilities, is we may see something like emotion and words are disconnected. So you may have had the experience of someone telling you something that happened to them. We'll talk more about this next week too. And they're telling you something horrifying, and just listening to it is hard. And you're just like, oh my God. But they're saying it to you very matter of factly. In fact, I had the experience once of working with a refugee he'd been a political prisoner and had been tortured. And I had not asked about this. We were nowhere near that. I think I asked how his day was or something. And he started telling the story of what he had experienced, unprompted by me. And it was like a robot was talking. He talked as if he were reading a shopping list to me. And I've been doing trauma work for a long time, 30 plus years now. And I've heard a lot. And I have a lot of capacity to stay and be present with somebody while they're sharing something distressing. And what he shared was so horrifying that I had a hard time staying in the room and not bursting into tears. I think I cried immediately after the session, but he had no emotion whatsoever. So that is, I think, a more common form of what we see with dissociating, where the feelings and the words aren't connected anymore. Why this is important is that you may be working with people, let's say on the autism spectrum, who already have kind of a flat affect, or they don't have a lot of vocal variation in their tone. And so it can be easy because of that for someone to go, oh, Kevin's telling this thing that happened to him, but it's probably not a trauma because he seems okay with it. No, that is not necessarily what's happening. It might be that you're seeing a combination of typical vocal flatness for him and a form of dissociating. So this is why we need to be sensitive to that, to dissociating coming in a lot of different sort of forms as we're looking at people. There's also a subjective sense of dissociating, and if you've ever worked with people with trauma, if you've ever experienced any kind of trauma, and it's this sort of like disconnected, floaty feeling. I have a client who refers to it as feeling kind of zoomy. People will sometimes experience a sensory shift. Like they will say they literally started looking at the room as if they were on the ceiling looking down at it. Children, I think, are more likely to experience that because they're already a little more fluid in brain processing. So if you work with a child who's experienced trauma, they'll sometimes say things like, well, I would just go into my stuffed animal and watch, and it was like it was happening to another kid and not me. That's a perceptual shift that is a form of dissociating. Now, at the top of this, we see, don't worry about the vagal stuff. That's part of polyvagal theory, which is a different thing for a different day. Engagement zone just means however you interact with the world. So again, the way somebody with a developmental disability or on the autism spectrum interacts with the world on a good day might look kind of different than how other people do it. But basically, it means you feel safe inside your body, your nervous system is in your window of tolerance, and you can interact and socialize with people to whatever extent is normal for you. So that's what these states are. And this is breaking it down into the 4Fs and the dissociation and the collapse. Okay, so I think this quote was in the other training as well, or maybe it was just the one, but I usually have two quotes from Bruce Perry because he's amazing. And he had this to say about working with children with trauma. He said, people usually want to teach other people from the top down, but the brain actually works from the bottom up. So now we're going back to that hand brain example that I was talking about, where actually what's happening is you are getting signals from your body. I guess we will talk about polyvagal theory for a second. You are getting signals from your body and from the environment around you, and then your brain may be activating the middle and the bottom to keep your body safe, and the top of the brain is relatively offline. So I'll tell you guys, Kevin mentioned some extra things, so I'm going to throw a little extra thing in here. Very quickly, the vagal nerve complex originates from one of the 12 vagal nerves in your brain. The 10th one, the vagal nerve, runs down the side and it attaches here, and it kind of breaks off in the back, and the back runs down your back, and the front comes down right through the front of your body, and it attaches to, after your larynx, it attaches to your heart and your lungs and your diaphragm, and then it wraps around to the front again and attaches to your bladder and your bowels. So it really goes through the whole core of your body. And it takes messages from your body to your brain and back and forth, right through the core. And it's helpful to think about this as like, imagine the shoreway. Just going to use a little North Ohio reference, okay? Now imagine that the shoreway was 4 lanes on one side and a bike path on the other. What we look at when we look at the traffic that goes up and down the vagal nerve complex is that 80% of it comes from the body to the brain, and 20% of it goes from the brain to the body. So if you've ever experienced like a panic attack, or if you've ever worked with people who have panic attacks and extreme anxiety, what you know is that you can tell someone, hey, nothing's going on, it's all okay, everything's fine. Does that instantly calm them down? No, no, it does not. And in fact, we know that working with anxiety disorders, and trauma used to be considered an anxiety disorder before it had its own category, working with the body is a much quicker shortcut into calming them down. So when I work with someone who's having a panic attack, I will get them to move their body or work with breath. Here's a tip. If someone's a little bit stressed, you can start with a breath technique, but if they're very freaked out, go with the body first. Breath is it's too much of an echo chamber. They connect to their breath, they hear that they're panting, they freak out, and they keep freaking out. So you might do some movement instead. But regardless, I'm going to do a somatic intervention. I'm going to work with the body, with the breath. That will start sending the message up to the brain, everything's cool. When we start slowing down the heart rate and drawing out breaths so we're not panting or hyperventilating, the brain gets that information and goes, oh, everything must be okay. And we stop feeling so anxious and we stop freaking out. So this is just one example, and we're learning kind of the mechanisms of why this is true, that the brain actually works from the bottom up. In part, that means we're taking all this information from the body. It also means that in order to get all of the brain working, you've got to get the alarm system calmed down. And this is where we get into safe, connected, and in control. When we are working with somebody, especially if they are in, let's say, hyperarousal and they're flailing around and they're being aggressive or they're running or they're screaming or they're doing whatever, and we want them to stop doing that, we often make the mistake of trying to go through the top of the brain first. What I mean by that is that we'll try to reason with them. Kevin, I don't know why you're reacting like this. There's no reason to throw a punch right now. I don't know, blah, blah, blah. Or I might try to remind him of consequences. Kevin, if you don't calm down and put that chair down, you're not going to get to go on the outing today. All of which is perfectly reasonable. The problem with it is that we're not paying attention to what's actually happening in the brain. So if my stress level has reached a point where that alarm system has kicked off and I am in hyperarousal, I'm mobilized, I'm blah, or I'm in hypoarousal, I'm shut down, I'm dissociated, I'm checked out. Either way, if you could do an fMRI of my brain at that moment, you would see relative inactivity up here. And keep in mind, we are often working with people who already have some struggles with connectivity in the front part of their brains. If they struggle with language or problem solving or impulse control, that is an activation and a connectivity issue, right? Along with if they've had any kind of physical damage. So already the activity in this top part of their brain is maybe not so robust, but stress will shut it off completely. It's almost as if this part of the brain detaches and stops talking to the other parts of the brain. So, as I said, 2 things to keep in mind. Number one, this is a survival mechanism that is millions of years old. It is to keep us safe. It is not intentional. It's not a behavior. It's not something someone is doing on purpose. And it is not, how do I want to say this? When I talk with my trauma clients, we'll talk a lot about this because their reactions are things that are usually what brought them to therapy. They're irritable or they're shut down or they're freaked out or they're whatever. And they don't like their reactions. And I get it. I understand. But I try to frame them as a survival mechanism and not a pathology. Do you know what I mean? That your brain's just trying to keep you safe. Now, maybe your brain's wrong about what's happening, or maybe the reaction isn't useful anymore. It used to be, but now it isn't. And we'll work on that. But I think it's more helpful to see it for what it is, which is this is an ancient tool that your brain and body have to keep you safe. So, first thing, this is millions of years old. Second thing, it is much, much faster than your conscious brain. Okay. Those of you who can swim, this is a weird example, but this is what I always think of. Imagine that you're at a 4th of July picnic and you weren't planning to swim. You're wearing your regular clothes. You weren't going to get in the pool. I don't know why, but you weren't. But someone like bumps you or something and you get knocked into the water. You'd be really surprised. And your conscious brain would take a minute to try to register what had happened. Would you just sink like a stone while your brain's putting it together? No. You'd already be doing your swimming motions in the water while your brain was figuring out, oh, someone must have bumped me and I fell in the water. It may seem like it's not a big difference. It's usually about half a second faster. But in brain terms, that is a huge amount of time. So what this means is that you are already in your state, your hyper or hypoarousal, long before your conscious brain can catch up, especially if that part of the brain is already kind of shut down because your brain is diverting resources. So all of this means that you are already throwing that punch or running or shut down or smiling or fawning or collapsing or whatever long before you recognize what's happening. Okay. And so again, if you work with people with trauma, or if this is something that, you know, people in your personal life or whatever, it's helpful to keep in mind when I say that people don't do this on purpose, I literally mean their brains cannot make a decision and do this. What I often tell audiences that when we are kicked into that survival mode, whichever direction we go, up or down, it is much more akin to a seizure in that sense alone of we're not in control of what's happening in that conscious control sort of sense. Okay. So what happens is our nervous system goes and kicks us up or down or whatever to try to help us survive whatever it thinks is happening. And our conscious brain has to catch up. And again, the folks we work with, that may take on a good day even a little bit longer than someone who's, let's say, neurotypical. But chronic trauma, that complex PTSD, repeated trauma, will create the same effect, even if you were born neurotypically. That the more this happens, the slower and harder it is for the cortex to get back online. So we know this, but we keep trying to reason with people and go, Kevin, you should stop doing A so that B doesn't happen, blah, blah, blah. We are trying to reason with someone when their reasoning brain isn't online. It's like you trying to send an email when there's no Wi-Fi. It isn't going to work, I think, because I think that's how Wi-Fi works. I'm not sure, but I think I'm right. So when he says the brain works from the bottom up, what he means, aside from the more elaborate polyvagal theory that we can include, is simply to say, you've got to get the brain to calm down first. You've got to turn that alarm system off. And then you can get that thinking brain back online. And this is why in my book and in the presentation that you guys saw, we talked about safe, connected, and in control in that order. So we're going to take a few more minutes. I'm going to go through safe, connected, and in control, and then we'll be ready for our break. Okay? So this is based on exactly the same thing that Bruce Perry is describing. People have to be safe before they can change what they're doing because they're not in control of what they're doing when they're not safe. So this may sound very odd. Let's say that, I don't know, Kevin is taking a swing at Lynn. And Lynn's like, hey, what did I do? And I need to get Kevin to stop doing that. Now, here I'm not talking about like restraint or anything like that. That's a different question and a very complex question. But let's just say I'm trying to get Kevin to calm down. All right. Then the first thing it seems like I would say is, Kevin, you need to stop that. You're going to hurt Lynn. But from a trauma-informed care, or sorry, trauma-responsive care perspective, safe, connected, and in control, the first thing that needs to happen is Kevin needs to feel safe. So the first thing I might do is say, Kevin, hey, Kevin, it's okay. You're safe. You're all right. You're okay. Now, Lynn might be going, what? Kevin's okay. How about me? But in this sort of brain science way, and thank you for being my participant in this, Lynn. In this brain sciencey way, really what I'm doing is I'm trying to get the amygdala to turn off, to go from red to green, if you will, from is Kevin safe? No, to is Kevin safe? Yes. And as you guys have probably already experienced and gotten very skilled at doing, even if you weren't aware necessarily of the brain science, you know a couple of things. If there's an audience get the audience out. If this person does better outside, get them outside. If there's somebody that's freaking them out, let's say this is happening out of a fight or a power struggle with another staff person, get the other staff person out. Because if for us to help someone feel safe, they've got to actually be safe. Just like, we're not going to turn off the smoke alarm if there's an actual fire. We're going to get out of the building. So you do need to make sure there's not an actual fire, that there's not something actually going on. And if there's something that's just the trigger, get the trigger away or get the person away from the trigger. In my experience working with teenagers, getting the audience away is usually easier than trying to drag away somebody who's freaking out. But whatever it is, try to get the environment as safe as you can get it. And then the next thing you're doing is you're reassuring that person, hey, you're safe, you're good, I've got you. We'll get through this together. It's okay. Now you notice that instinctively, just as you guys do, I'm shifting my voice. My vocal tone and color has changed. My body language will probably be like, hey, I'm very little. So it's not as big of an issue for me. But when I first started working with teenagers, we had a supervisor who was super duper tall. He was like 6'4", and he had long shaggy hair and this big dark beard. He kind of looked like a Sasquatch, actually. And I noticed early on that when he was talking to a kid who was upset, he would crouch down and sit next to them. And he would usually find a way to be at least on their level, if maybe not a little bit lower. Because being told calm down from this huge tall person is maybe not so reassuring. So we're doing all of these things that indicate you're safe with me. The other thing it's doing is taking us to that second step of connected. It is immediately creating warmth and connection. Now, some of you already have a relationship with the folks that you work with, and all you need to do is walk in the room and they feel better. And you can be like, hey, man, what's going on? And they start cycling down, right? But this works even if it's the first time you've ever spoken to them. If you've ever worked in crisis, or if you yourself have ever been in a crisis and you're talking to an EMT or an emergency room nurse or something like that, you know how instinctively we read people to see if they are going to be warm and caring. And when someone has a little bit of warmth and a little bit of caring, maybe they even say something like, hey, it's going to be okay, we're going to get through this. You know that visceral feeling in your gut that makes you go, ah. It doesn't magically fix everything that's happening. It doesn't mean that you suddenly went from having a terrible day to a great day, but you can start cycling out of what's going on. You can start to think a little bit. Maybe you can start to talk a little better. You can go on to whatever that next step is. It doesn't take much for most of us. Just a little bit of warmth, a little bit of caring, and our brain can feel that this is somebody that we can connect to in this moment, right? And then the third thing, of course, is in control. I'm going to come back to connection in a second. In control doesn't mean I am the boss of everyone. In control just means neurologically, the thinking part of my brain is getting back online. And I can, to whatever extent I'm usually able to do it, I can now think about cause and effect. I can think about, oh gosh, I don't like it when people are mean to me. So I don't want to hit my friend because they won't like, you know what I mean? Like I can start using logic. I can start projecting into other people's experience. I can think about the future. I do want to go on that outing. So I think I'm going to put the chair down. Now I can start thinking, and that means that I can choose my behavior. I need to be clear about this. I might still choose to be a jerk. I might still choose to throw the chair, but in that moment, now it's a behavior. Now it's a choice. Before, it was just frantic brain activity. Okay, so we want people to start moving into that state of being more in control. Why does connection come first? Well, it has to do with how the brain is built. Your brain can do an unfathomable number of things, and I think I write about this in the book too, that I saw an estimate once of how many operations your brain will do in your lifetime. And it's like 11 jillion billion D. I don't know, a number I could not comprehend. At the same time of this extraordinary complexity that we're still just learning about, your brain is also very simple because it's organized on some very simple principles: up, down, back, front, side to side. And it's also organized in terms of on and off. which makes sense, right? If I don't have a way to have an off switch, then my brain tells my hand to go scratch my nose because it itches, but I can't stop and I keep going until my nose falls off. And in fact, there are some neurological disorders like Parkinson's disease where damage to the brain has created difficulty starting a movement, but also difficulty stopping a movement. So people will keep going with the movement. That, in very, very overly simple terms, is the on and off switches are broken. And the same is true for that activation pattern that we've been talking about, the hyperarousal and the hypoarousal. There's an on switch and there's an off switch. So I mentioned early on the chemicals of norepinephrine and cortisol. They are among the neurotransmitters that start getting pumped out by the signal from the amygdala, danger, danger, danger. Your brain starts pumping out norepinephrine and cortisol. That, as I said, signals the release of cortisol and adrenaline in the body. And now we've got this whole mobilized system going on. Okay? That is the on switch. We could call it the on switch for fear. But because there's an on switch, there's also an off switch. And the off switch are two neurochemicals that you have definitely heard of. One is serotonin and the other is dopamine. They're not the only ones involved, but they're some of the primary ones involved. Okay. Now, here's what's interesting about, let's say, in this corner, we have dopamine and serotonin, and in this corner, we have cortisol and norepinephrine. They are chemical antagonists. What that means is when you've got norepinephrine and cortisol, and you start having more dopamine and serotonin floating around, this stuff actually breaks this stuff down. Just like if you have a pan full of greasy water, like you're washing the dishes and you've got a pan you fried something in, and that grease layers on the top, if you drop a drop of soap onto it, it breaks it up, right? So it's called a surfactant, if anyone wants to know more about that. So we can use that as a rough analogy for this. When there's more dopamine and serotonin available, it literally breaks down these chemicals in your brain. As the levels of dopamine, so many chemicals to say, you guys. As the levels of norepinephrine and cortisol start dropping in the brain, it helps to stop that signal that's going danger, danger, danger. So the other thing that's happening is that we are connecting with someone. The chemicals of serotonin are what we typically connect with rest and digest. They're the chemicals, it's the chemical of calm, it's the chemical of feeling okay. It's kind of like if you've ever eaten a meal when you were stressed, you probably noticed you had a harder time digesting it. You might have had more indigestion later. Whereas if you're relaxed when you're eating, that's less likely to happen. The presence of serotonin in your brain helps your body relax enough to digest easily. When there's not as much serotonin and you're more stressed, it doesn't go as well. So when we have more serotonin, we can calm down. When we have more dopamine, we're getting the reward of connecting to another person. Dopamine actually gets released in our brain from all kinds of things that human beings typically really enjoy, like sugar, fat, gambling, shopping, little ping, ping, ping rewards on social media or a game you're playing on your phone, sex, cocaine, all the things people like release dopamine in the brain. But one of the fastest and most powerful ways to get a human brain to start releasing more dopamine is through a warm human connection. So it's maybe not practical or ethical to give people a bunch of sugar and cocaine, but what we can do is create that warm bond with them, and that will encourage more dopamine and serotonin to be released in the brain. That allows the thinking brain to come back online, and now we can start talking. Now we can start reasoning. Now we can start problem solving. But to go back to this slide here, what Perry is saying is you've got to deal with the bottom and the middle of the brain first, and then you can get the thinking brain online, and then you can be doing all the talking and teaching that you want to be doing. So safe, connected, and in control. I talked a little bit here again about the vagus nerve. We don't have to worry about that, at least not for today. And this is why we say these things in this order. People need to feel safe, they need to feel connected, and they need to feel in control before we ask them to do anything else. And I think that this is really one of the key points about trauma responsive care is this isn't like extra if I've got time. This isn't frosting. This has got to be the core of how I interact with people before I'm asking them to do anything else. Certainly, if they are knocked out of their window of tolerance, this is how I get them back into their window of tolerance. And I would argue that even if I'm not sure that they're in their window or not, anytime I'm interacting with somebody, I want them to feel safe, connected, and in control. And this is what takes us into the universal precaution element of TRC. So this is a good stopping point. It's a little bit early. Um, so let's go ahead and take our break. Oh, actually, I guess it isn't. It's right about 12. So we're going to take a 15-minute break, give everybody a chance to get up and stretch and do your things. And we'll come back here at 12:15, and we will wrap up talking about universal precautions and also the CALMER protocol that we can use to get ourselves into a position to help other people feel safe, connected, and in control. So see you guys back here at 12:15.
Okey dokey. Yes, ma'am.
Okay, so we've got the recording back on, and I have one comment in the comment section from Julie. I agree with the diagnoses 100%. Thanks, Julie. Let's
Really?
take a,
Everyone is coming back shortly, so I unmuted, but they're making their way shortly back to the room.
that's fine. Hi, everybody. I always like to do like a little bit of chit chat as we're coming back from a break because everybody's like kind of filtering back in. So those of you who are here and as people are entering the room, if you have a question, since we're unmuted or there's something you want to share, I'd love to hear what your thoughts are at this point.
Well, Laura, this is Patricia.
Hi, Patricia.
I love your humor that you inject with everything. I just, I did just, yeah, we heard like the blurt out at one point, that was me laughing, but yeah, so. I think you take something very complex and make it, easy to understand.
Thanks, Patricia.
Appreciate
Thank you. I very much appreciate that. Anyone else
Patricia-
want to say anything wonderful about me before we
Patricia,
get
I know you're not saying that she's funnier than me.
We'll talk later, Patricia. I know what you're really saying. Okay, it looks like we've mostly got folks back. So as I said, we'll have time towards the end, and we know you guys. And so, if there's anything that we didn't get a chance to get to, whether, we're going to be meeting again next week, and if we talk more about stuff or whatever we end up doing in the future, I'd love to hear more about kind of how you guys are thinking about all of this and the work that you're doing. So I'm going to go ahead and jump back into this and resume the share. So hopefully everybody can see that. And we talked about safe, connected, and in control. And when we think about these two factors, I think that come together, one being the number of people that are exposed to potentially traumatizing stress, and the other being how foundational it is for someone to feel safe, connected, and in control before really we can ask them to do anything. Then we start talking about TRC as a universal precaution. Here we say universally applied, but I like using universal precaution because all of you guys had to take first aid training. You probably have to get certified every couple of years. And I talk about this a lot, and I wrote about it, that we sometimes forget what an elegant, brilliant idea universal precautions really are. That if we just talk about illness, most of the time for some of these like bloodborne diseases and things that we're trying not to be exposed to, you can't always tell that someone's sick. Or respiratory illness or COVID, part of what was so challenging was that people could be contagious before they had recognizable symptoms and even thought to test, right? So COVID's been very interesting because I've been talking about universal precautions for TRC for nearly 2 decades, I guess, going on, and 15 years, I guess. And during COVID, we got this like perfect illustration of what a universal precaution should be. wherever people landed on the mask debate is kind of a little bit different, but this idea of like, you can't tell when somebody's sick. They may not know that they're sick. So how do we deal with that, whether that's distancing or masking or testing or whatever? I think that really brought home to us again how important it is to treat people as if, and it can be tricky to balance that, but this is where I think TRC works really well. So, for example, let's talk about a bloodborne illness like hepatitis. I could be talking with somebody, I don't know, let's say Patricia, and she looks fine. She looks absolutely fine. She doesn't know she's sick. She doesn't feel sick. And I don't know, she gets a little cut or something, and I'm going to, give her a Band-Aid or something. And if I've got a tiny little break in my skin, a tiny little cut or scrape or whatever, and I look at her and I assume she's okay, and she's not, that she has this virus, the consequences for me can be catastrophic, could be life-threatening. If I look at her and say, gosh, Patricia, I don't know if you're sick or not, so I'm going to give you 6 weeks of antiviral injections, and then you can have that Band-Aid that we talked about. That's not really very practical. And it's also really invasive, right? So we're way too far on the other side of that. And I can't go, hang on, Patricia, I know you want that Band-Aid, but I'm just going to run your blood down to the lab. It'll take about a week or so to get back. And then we can see if you haven't bled out, I'll go ahead and put that Band-Aid on, right? Like that's not doable either. So when you think about something like putting on gloves, which is universal precautions in first aid, it hits that balance beautifully. How much does it cost to get a pair of latex gloves? Fractions of a penny, I'm sure, if you looked at each individual pair. What does it cost then if I, am going to put a Band-Aid on Patricia's cut and I don't know if she's sick or not? She may not know. So I just put on a pair of gloves, and when we're done, maybe I use a little bit of like bleach water or something to clean up, whatever. How much did that cost? A few seconds and maybe fractions of a cent. Whereas if I go the other way, it can cost me potentially everything. And I can't do something that goes too far and is invasive. So gloves are that perfect balance point. And I think that trauma responsive really is similar in that we're just saying that people need to be safe, connected, and in control. We're not saying they have to be diagnosed with trauma. We're not saying they need, 3 years of trauma therapy. We're not saying they need medication. We're not doing any of that. We're simply saying, before I want to deal with somebody who seems dysregulated, I want to give their brain a chance to regulate by helping them to feel safe, connected, and in control. And in fact, anytime I'm going to ask anyone to do anything challenging, I think sometimes it's easy to forget how scary some of the things we ask clients to do really are. I'll tell you this, when I've worked with different populations of people, but I'll use teenagers as an example, I also supervise staff. And if any of you have ever been supervisors, you know that we would be constantly telling our teenagers, you need to use your words, you need to express your feelings appropriately, you need to use I statements, blah, blah, blah. You need to handle conflicts appropriately. Do you think all the staff were doing that with each other? No. So it's interesting to me, and this is maybe a whole nother training for another day, of like how often we are asking things of people that in reality we find hard. Maybe not in the same context. I'm not going to struggle with some of the same things that, let's say, a kid with autism struggles with. But do I struggle when I feel out of place or overwhelmed or misunderstood? Yeah, I do. It stresses me out. And so I like the fact that we can say that everyone really prefers to feel safe, connected, and in control, especially before we're asking them to do something challenging, or, as we've been talking about today, when they appear to be dysregulated. And dysregulated, as I'm sure you guys know, but I use this and typically introduce it a little bit earlier. Regulation in this sense means that all the regions of the brain are talking to each other. No one region is too fast or too slow or too active or too inactive. And there's, reasonable balance in the activity around the entire brain and the entire nervous system of the body. That's regulated. When someone is dysregulated, they're no longer in that window of tolerance. And clearly, some things have sped up and some things have slowed down. So when we see someone that's dysregulated, or even when we're just asking them to do something challenging, or just how we want to be interacting with them day to day, safe, connected, and in control, I think has that same balance of it's not invasive, you don't need to run a bunch of diagnostic tests, and it's not going to hurt anybody. Whenever I do this with big audiences, I'll sort of do this whole bit where I'm like, okay, raise your hand if you don't ever want to feel safe, connected, and in control. You prefer terrified, isolated, and powerless. And there's always some jokester who raises his hand and we all have a laugh. But the point is, nobody wants to feel that way, ever. So trauma responsive care, making sure that people feel safe, connected, and in control before we ask anything else of them, I think really does make sense as a universal precaution. And then again, when you look at the rate of people who have been at least exposed to potentially traumatizing levels of stress, when you're talking about more than 90% of a group of anything, it's kind of everybody. And I think Kevin makes this point well in his book, and he'll talk about this next week in terms of burnout, paying attention to the emotional needs of the people we work with and the people we supervise. Really can start with the same formula of do they feel safe and connected and in control? So that's what we mean when we say it's relationally based, it's universally applied, and it's organization wide. And now we're going to jump into boop, boop, boop. I'm going to go through some of the stuff because there's, as I said, always more that I want to tell you. But we're going to talk about the CALMER skills. And I feel like I'm in with some kindred spirits with this group. Sometimes when I go to talk to an audience about trauma responsive care, and I understand this place, I understand where they're coming from. There's sort of this thing of like, oh, good, you're going to tell us the magic words or the magic formula to get this individual to do the stuff I want them to do or to stop doing the things that I don't like. And I wish that were the case. And as Kevin likes to joke, we would make much more money. But in a way, I kind of don't wish that, because I really think, going all the way back to the beginning of our conversation today, it's so easy to see us as us and them as them. And really creating an environment in which someone feels safe and connected and in control has much more to do at the beginning with where we are. And again, whether you've identified this or explicitly or not, you guys already know this. You've watched a parent or a teacher or a staff person or a cop or somebody get like super into a power struggle with someone, and then you watch that individual go spiraling right up, and then it's the individual who's going to be in trouble or experience the consequences or whatever. And on the other side, as we were saying a little bit earlier, if you're the person who walks in the room and you're calm and you're chill and your vibe is relaxed and you're looking for ways to connect and help people regulate with you, it's not magical, and people might still be having a hard time and you might still have some crazy situations, but you're already starting at an advantage. And when you're here and someone's here, you're giving them something to resonate with, right? You're giving them something to modulate with. If you're up here and they're up here, you're both going to stay up here. So in the most practical way, the best way we can start helping people to feel safe, connected, and in control, the best way they can start healing from their trauma and maybe doing something different that we want them to do, yay, we have to start with us. We have to be able to identify where we are and maybe work with that a little bit so that we are reasonably regulated ourselves. We don't have to be, in some state of perfect Zen, Buddha-like calm. I don't mean that. I just mean relatively grounded, relatively regulated. And we need some skills for how to do that, because our jobs are stressful. And the people we work with sometimes do things that freak us out, or we have our own things going on before we even got to work. We maybe have our own histories. We get our own triggers. So I really want to treat us with that same tenderness and care that we treat the individuals that we support. We deserve to know the skills that we need to feel safe, connected, and in control for ourselves too, right? So the first one, as you can see, is just check in, which was a simple way to make it fit into the acronym, to say you can't change something if you don't know what is happening, right? You can't change the temperature in your house if you don't have a thermostat that tells you what the temperature is. So checking in may sound kind of like obvious, but we tend to skip that step. And so this just means, what are your sensations, feelings, and thoughts right now? And remember when I was telling you guys a little bit about the polyvagal nerve network? This is, again, part of a different, larger training that I do about that kind of advanced trauma stuff. But we come back to that same thing again and again, that emotions are in the body. The majority of information going back and forth between your brain and your body is 80% from your body. So start with your sensations. When I worked with teenagers on things like anger management, they would always insist that it just came over them. They would just like Hulk out, and there was no warning. And it's true that some of them had very short fuses and they would react with anger very quickly. That's correct. But when we started to break it down and I would challenge them a little bit, they would start to identify there were some indicators, there were some signals inside them. And typically it's in the body. The body is always faster than the brain. So before we recognize how we're thinking or feeling, it might be easier to recognize, oh, my face is getting hot. I think you guys can probably tell from this that I am among the pale peoples. And when I get emotional, my face turns beet red. Like I could be a lighthouse on Lake Erie just with my face. So I've learned that when I'm getting upset or frustrated or flustered or stressed, I will feel my cheeks burning. And sometimes that's the first thing I notice, not the feelings that are building up or the thoughts that I'm having, but that sensation. Or I might hear my voice quaver, whatever that is for you. And so I really, really suggest to people that they start mapping these things out for themselves. A lot of times we kind of know them, but maybe we haven't thought about it really specifically. So thinking about what are the sensations in your body when I'm nervous, like before a presentation, my stomach's upset. I don't usually eat a whole lot. I know to associate that with, oh, I think I'm a little bit nervous. Then you go up to the emotions. I'm nervous, I'm scared, I'm worried, I'm sad. You guys know the 5 basic feelings, right? Happy, sad, scared, mad, shamed. So, and then the variations of those. So, what are your emotions? Start with the body. Then, what are your emotions? Because your emotions are also in the body. And then you think about the thoughts. What is your self-talk, right? So, times when I get really stressed out or I'm really nervous or worried, sometimes my self-talk can get pretty negative. And I'm like, why didn't I study harder? Why didn't I do this? Blah, blah, blah. Which is, I think, not maybe the most helpful thing I could be doing. But I can't make any changes to anything that's happening if I'm not in tune with what's going on. So starting with sensations, feelings, and then thoughts. What is happening right now? Then the next thing, and these things are so close together that they can seem simultaneous, but I think it helps to break them apart, is accept whatever the answer is. And again, I know that that can sound kind of, duh, but really, if you think about it, we tend to have a lot of judgments about ourselves, a lot of judgments about how we're handling things. And my experience is that especially people in the mental health world, or human services generally, we have a lot of opinions about how we're supposed to be. We're supposed to be always calm, always knowledgeable, always have the right answer, the solution, always emotionally available. I don't know that that's really so practical for any human being to ever be able to always do that all the time. And so, again, just speaking for myself, I can be very critical, or I shouldn't be feeling that way. Or, if I'm working with a client, I'm not supposed to let them get to me. But we're human and they're human, and people can be really annoying. And so, if I can just accept without judgment however I'm feeling, this individual has made me feel triggered or stressed or frustrated or angry, or whatever it is, the situation, whatever's going on in my life, it doesn't matter what it is. If I can decide that whatever I'm thinking and feeling is okay. Now, it doesn't mean that it's accurate, right? I might be not seeing something or overreacting or whatever. It doesn't mean that that's how I should base my behavior. If I'm feeling angry, that doesn't mean that it's necessarily okay for me to lash out or yell at someone. I'm simply saying, whatever my internal experience is, it's okay. So check in, what is going on with me? What am I sensing, feeling, and thinking? And then whatever that is okay. I'm not going to yell at myself or beat myself up about it. And then the next thing really just follows that thought, which is, how can I actually do the opposite, which is say or do something loving and kind for myself right now? Which, if you haven't had all the brain science that we just spent hours on, maybe sounds kind of gooey or corny, but actually, we talked a lot about releasing dopamine and serotonin into our brain and trying to break down the norepinephrine and the cortisol from stress and fear, right? Well, we talked about connecting earlier as something that's happening between two or more people, but it's also something we can do with ourselves. In fact, this is a lot of the trauma work that I do with clients. Where is that kind, compassionate voice that I can have for myself? It doesn't mean I love everything I did. It doesn't mean that I can't think critically about something later and go, oh, I think I'll handle it differently next time. It just means, hey, you're doing okay. This is hard. And that might be just a moment of self-talk. Or it could be something you're doing to support your body. So what I talk about with audiences a lot is that I'm kind of vulnerable to low blood sugar, and I can get kind of shaky and irritable if I don't eat pretty regularly. And I know that about myself. I've known that for a very long time. But still, if it's been a really long day or it's been really busy or crazy or something, I can suddenly realize that my blood sugar is too low. And I have a choice at that moment. I can yell at myself and I can be like, ugh, what is the problem with me? I knew I was supposed to bring snacks. Why didn't I bring snacks? Blah, blah, blah. Or I can just do what my Jewish grandmother said and just eat something. I can just eat something. I can have a drink of water. I can step outside and get a breath of fresh air. A lot of times when we're focused on other people and what they need and how we support them, we're not always doing so great at supporting ourselves. And sometimes our body needs a breath of fresh air, a little drink of water, maybe a little snack. So doing something or saying something that is kind or compassionate or supportive to me, again, our instinct is to immediately focus on the other person. But even if this just takes a few seconds, if I'm dysregulated, I've got to regulate myself to be able to work with them. And this is another thing that I can do in this progression. I can do or say something lovingly kind for myself. Now, let's talk about mindful. Mindful is a word that gets thrown around a lot. And it can, like a lot of things that get sort of popular, it can mean different things to different people depending on what you're talking about. But the most simple definition of mindful simply means you are paying attention to what is happening. I'll give you an example of mindfulness practice that I did when I taught a class about this at OSU. So I can talk to you guys and I can hold this cup and I don't have to think about holding the cup. My hand's going to basically remember to hang on to it while I'm talking or making my point or gesturing or whatever. But if I stop and I notice that I'm holding the cup and I can feel the weight in my hand and I notice the warmth of the tea and I look at and I see the design on the cup, well, now I'm mindful, right? I'm aware of what is going on. In this case, I'm aware of the fact that I'm holding this cup as opposed to just holding the cup. So really, mindfulness is simply paying attention to what is actually happening right now. And very important in our field, what is not happening. So I mentioned this before, and I'll just sort of continue with this image. We have seen people get into situations that maybe were already, kind of tense, an individual was being kind of challenging or whatever. Again, I worked a lot with teenagers when I was in the mental health community. And that's kind of their deal, is to be annoying and challenging. So, there's something that started it for sure, but then you see a parent or a staff person or whomever, and they get locked in. And now they're in a power struggle. And now we're just watching it go blah, 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 and it explodes. And a lot of the time, it didn't have to go that way. It didn't have to get so escalated. So what I observed as a supervisor, and then later at the state, I was on this kind of nerdy but cool committee that reviewed major unusual incidents around the state. And it was kind of fascinating. And what struck me was what I had already started seeing in a much smaller way when I was a supervisor, which was it's when someone else decides that they're gonna control the situation. And when you ask them, the staff person, the cop, the family member, whomever, why did you do that? They will usually say something about the future. Well, I thought that he was going to ... or I didn't want this to turn into ... In other words, often, not always, but often, what started that escalating kind of arms race was somebody thinking about what might happen or what could happen or what might be about to happen rather than what was happening right now. And I'll use another example from when I worked at a crisis shelter. So we would have to call the police sometimes because there would be a fight with kids that we didn't want to break up, or no, we didn't want to break up. It was dangerous. Now we were like, yeah, let them fight. Let's see what happens. But there would be like a physical fight that we needed help with, or a parent would show up drunk or something. We needed the police. So they would come. And I will say that my experience tended to be sort of in one of two extremes, not very often in the middle. And it looked like this, that when a police officer came in and he or she was calm and moving kind of slowly and talking kind of slowly and asking questions, and the vibe was just sort of down here, I knew that chances were that this was going to be resolved relatively peacefully. And what I learned was that when it was the opposite, and it did always kind of seem to be one or the other, and they would come in just like really hot, and they were yelling and like, you know, putting their hands on people right away, then I knew somebody was leaving in cuffs. This was not going to be a peaceful resolution to this. This is not meant to be a conversation about policing in this country, which is a very big, very different conversation. I'm simply sharing my experience that when cops came in already, you know, kind of already reacting to something in case something was gonna happen, it almost ensured that that's how it went. And when they came in a little bit more low and slow, it tended to not happen. And I think we can do the same thing. So I'll use Kevin again as an example. If he's an individual and we know that he's a runner, when he gets stressed out or triggered or whatever, he tends to run out the door. Well, we have to pay attention to that, right? We cannot allow him to race out the door and potentially, you know, get very seriously hurt. At the same time, let's say that before he starts running, he just shows smaller signs of agitation. So he does a little rocking and he's doing some stimming or whatever. And I'm like, uh-oh, this is what he does before he runs. Would it be smart of me to look over at Patricia, who's working the shift with me, and go, hey, why don't you go over and stand by the door? Yes, that would be smart. Do I need Patricia to leap across the room and tackle Kevin? No, I really don't need that, because that's not what's happening. It might happen. If that's what happens, we'll respond to it, and we can take reasonable precautions. Having somebody stand by the door is a reasonable precaution. Leaping across the room and tackling them is not. And I'm using sort of a, you know, kind of silly, exaggerated example, but I do think we see this a lot in mental health and in DD, where people get worried or freaked out and they start escalating, and then the individual escalates, and now we've got an incident that maybe didn't need to be as big as it turned out to be. So all of this is simply to say, once you've paid a little bit of attention to what's going on inside you, and you've been able to go, hey, it's okay, you know, you're all right. Now you can look at what's happening around you. So we've gone from focusing inside to focusing out. What is actually happening? What is not happening? Another thing that always amazes me is when something ends in a restraint or punishment or whatever because someone was destroying property. I've worked at a lot of social work, mental health, community settings in my life. Do you know the kind of property we have? It's usually awful. It's just crap we got from United Way or, you know, Goodwill. So, do I want them to keep breaking stuff? No. Do I need to run over and restrain them and tackle them? Maybe not. So the more that we're mindful and present, the smaller that list becomes, I think, of the stuff that we've got to like really, really strongly react to, and stuff that maybe we can sort of step back and see what's going to happen next. All right, so mindful, just look at what's going on. The next thing is express. And this we'll come back to a lot next week when we talk about burnout and empathetic distress and all of that stuff and self-care. But we walk around with a lot. And this just sort of is something I've been starting to talk about more. So you guys are one of the first audiences to get this. But I really think it also kind of messes with our threshold. Some of us, depending on what we do, see so much struggle or suffering or trauma, either in what we're watching someone deal with, or we hear about a trauma history or whatever, that we tend to think of that as like not that big of a deal. And it's easy to lose sight of what it means to walk around with that stuff. We may not be thinking about it. We may not be talking to people about it. But if you spend some time in this field, you can carry a lot of really hard things around with you. And then, especially if you combine that with what we've been sort of talking about, a situation that blows up or that was really challenging or was really pushing your buttons, that's a lot. That is a lot to handle. So it's very important for us helpers that we let this stuff out somewhere. And of course, we have different ways of doing this. In my example, Patricia and I are staff people working a shift together, and I can just say this to her. What the hell was that? Or whatever, or we can talk later or debrief. At various agencies where I worked, we had a policy about debriefing after unusual incidents as soon as possible. I think the requirement was within 24 hours, but we usually tried to do it like immediately. Not just because we sometimes needed to document something, although unfortunately we did, but also because we knew staff needed it. We didn't want them going home and just like, wandering around like a zombie. They needed support. So it might be something that's happening right away, or it might be something that you do elsewhere when you talk to your family or your friends. And here's another little trap that we'll talk more about next week, which is if you are exposed to challenging stories or challenging situations or upsetting things, my friend who works a lot with trauma with law enforcement and first responders deals with this. Your instinct is to protect the people in your family or in your life. You don't want them to have to hear the stuff that you had to hear. And I get that. But if we're doing that, if we're kind of protecting people from the stress or the suffering or the upsetting things that we're exposed to, it's got to go somewhere. In my private practice, I work a lot with therapists, actually, because therapists need support too. Or you might find that you're talking to a trusted friend or a colleague, a supervisor. Maybe you're journaling. Maybe you're talking to yourself. Maybe it's a clergy person. Maybe it's God. Whatever that is, that stuff has to have a place to go. We can't just carry it endlessly, which we tend to do. I don't think we intend to do that, but we tell ourselves, yeah, I'll take care of that, but I've got to just get through this first. Or, well, I'm just going to attend to this person's need, and then I'll think about me. It's okay, I get it. But if you're sitting here today listening to this and you're one of those people that carries more than you let out, it might be worth thinking about where where do you find that support and that outlet for you? And now it's time to respond. So obviously we can sort of put these together in different ways. If you're doing all of these things in the moment in a situation, you're probably not going to go, hang on, everybody, I'm going to go journal for a while and then I'll come back. But my point being, respond can be in the moment where maybe you just did some of these steps, but you paid attention to where you were, you accepted it, you tried to be sort of supportive to yourself, and you tried to pay attention to what was actually happening and not what you were afraid was going to happen. And now you can respond in a more modulated and appropriate way. You're less likely to overreact or underreact, which, not coincidentally, is the same kind of framework that we talked about for the nervous system's activation, right? We go up or we go down. We can do that in our behavior too. We can overreact and kind of freak out, or we can underreact and minimize or check out. This is just another way of talking about regulating so that we can be present. Reacting might also mean, responding might also mean taking steps afterwards. So Patricia, I'm going to use you again as an example, but now you're the supervisor. And I might need to come to you and go, hey, the way that went down, we could have really done that differently if I'd had more training, or if we served snacks earlier. Clearly, I'm very snack focused. Whatever it is, if I think there's a systemic or a program thing that we can talk about or work on, or I've got suggestions or thoughts about, it's important for me to do that too, to feel like I've got input where I'm working. And this is actually something Kevin will talk about a lot next week in terms of how much staff feel like they can impact the conditions in which they're working. So if I've got something that I need to process or share or talk about with a supervisor, this is a way for me to do this in a way that's regulated instead of just stomping into her office and yelling, which people never do, Patricia, I'm sure. Never happens to you? Yeah, that's what I figured. Okay. So I want to do a quick exercise with you guys that I often pair with the calmer skills, because sometimes, as I was talking about earlier, if we're a little stressed or we're a little dysregulated, we can kind of remember these steps and go through them, and it'll help to ground us, and that's great. But if you're really panicking or really distressed or really freaked out, it can be hard to slow down enough to do that. So there are some movement techniques that I teach in longer trainings, but I am going to teach you guys a quick sort of breath technique that you can use in the moment. It's very fast. No one will know you're doing it. So you can be in the mix with everything that's going on, or in the family meeting or the staff meeting or the whatever, and still have this technique that will help you be able to get into using your calmer skills. So, as is always the case, this is totally voluntary. So if you want to participate, cool. If you don't, totally fine. And all we're going to do is we're going to sit. I'm going to cue you to get sort of comfortable in your body a little bit. So generally, I recommend that if your feet comfortably touch the floor, it helps to have your feet flat on the floor. I'm a petite American. My feet don't touch the floor in a lot of chairs. So do what's comfortable for you. I also like having you sit kind of upright, so that if you're sort of like this, when we're sitting more upright, it just lets the air come in and out of our body a little more easily. But I don't want you to be like tense or rigid. So if that's not comfortable, if you can grab something to put behind you, that's fine. Basically, I want you to be awake in your body, but not uncomfortable. So if you need to take a second to get some more back support or whatever, go ahead and do that. I'm also going to suggest that you take a moment and put distractions away. So if you've got your phone nearby, which we all do all the time, maybe just turn it over. If you've been taking notes or something, just set those down. And you can choose to close your eyes if that's easier for you. Some people don't like doing that, and that's fine. You can just rest your eyes maybe on the table or the corner or something that's kind of boring, that's not going to grab your attention. So we're just going to settle into our body. If your ears are kind of creeping up towards, if your shoulders are creeping up towards your ears like mine do, maybe take a breath and let your shoulders drop a little. Just get grounded into your body a little bit. Someone asked Bessel van der Kolk, the trauma guru, what grounded means. And he's Dutch and very like earthy. So he said his definition of grounded was, you know that your feet are on the floor and your butt is in the chair. Okay, so maybe we can just do that. Let yourself know that your feet are on the floor and your butt is in the chair. All right, so what we're going to do now is we're just going to breathe. And you don't have to do it in any special way, like, through your nose, your mouth, whatever's comfortable, that's fine. But when you breathe out, and I will cue you to start, you are going to say a phrase to yourself in your head silently. All right, you're not saying it out loud. And this phrase should have a couple of characteristics. First of all, and most importantly, it should be something that's meaningful to you, something that is calming or inspiring or reassuring to you. A lot of times people will take a phrase from like their favorite prayer or poem or song lyric. It doesn't matter. Just so that it's meaningful to you. And the other thing is that it needs to be short enough that if you were going to say it out loud, you could do it in your out breath only. Okay. So let's say that I choose the Lord's Prayer. I could say, Our Father who art in heaven. I can't say the whole thing in one breath or I'm going to pass out. So you're just going to take a little piece of it that if you were saying it out loud, you could say it comfortably in one out breath. So take a second and think about a little phrase that's meaningful or reassuring to you. Okay, so whatever phrase you have is great. And I'm going to time this on my little phone thing here. And when I tell you go, begin. You're just breathing and saying your phrase to yourself on your out breath only. When you get distracted, don't worry about it. Just come back to your breath and your phrase. Okay, go ahead and release that. If you've closed your eyes, you can open your eyes, or you can lift your gaze. And now let's just do a little quick check-in. This would be a good time to unmute if somebody can do that. And for the rest of you, starting with your body, working up, sensations, feelings, and thoughts. What do you notice having done this exercise from before? In other words, what's different?
Yeah, it was hard to do because the phrase that I typically focus on when I'm doing that is the entire 23rd Psalms. So I'm
I love
trying
that song.
to out breath, and it was just difficult to get that kind of concentration going when I'm used to doing this in a different way.
Well, let me suggest this to you. I think that is a beautiful, longer form of this practice. So if you find that sitting and breathing and going through the entire psalm is helpful, that's totally good for you. You can also kind of do both, right? So there may be times when you've got more time and you want to sit and contemplate and go through the whole psalm. And then I'll come back to this in a second about why practicing with a little phrase might be useful for you in a different way. But it's all good. Anyone else notice anything about when we were doing that or how you feel now compared to before we started? What do you observe?
Focused for sure as you were doing it. I was thinking of my out breath and trying to coordinate the two things.
It's interesting how there are a lot of mindfulness practices where we feel a little bit more rested in our brains just because we gave our brain just one thing to do. And in our world where we are constantly finding more and more ways to be more and more distracted, not always, but often it's restful, sort of, just to only do one thing, which is kind of nice. Anyone else notice anything else from doing that exercise? And we really only did it for about 75 seconds. Anything in your body or your feelings or your thoughts?
Releasing.
Releasing. Yeah. So let me tell you a little bit about what this exercise is and why it works, or what we know about what it works. This was developed by Dr. Herbert Benson when he was studying stress, and this was in like the 70s and 80s. We're all much more aware, I think, as a culture about the effect of stress on the body, but at the time, we really didn't know how they impacted each other. And he was interested in reducing stress for things like high blood pressure, diabetes, heart disease. And so he had his patients and he taught them to do this. He would have them do it, like I said, we did it for about 75 seconds. He would have them start at like 2 minutes, and I think they would work up to maybe 10 minutes or something. And they would do that twice a day. And what he found was what he expected, which is that after a few minutes of doing this, their heart rate was slower, their blood pressure was a little bit lower. And of course, if you only do it once or twice, then everything would go right back up as soon as they were done. But when he had patients do it regularly, twice a day, they had lower blood pressure and it started to stay lower. Their heart rate was lower, all of that good stuff. And that was what his hypothesis was, and that's what happened. But what he didn't expect was something that his patients started telling him. And that was that, when they did this practice regularly, when they found themselves in a stressful situation, like they were stuck in traffic, they could take a breath and say their phrase to themselves. They could do that a couple of times. And they said it was sort of like it cued their body what to do. Because remember what we said before, the bad news about trauma is that our brain gets good at whatever we ask it to do a lot of. But that's also the good news. So the good news with this is that if this exercise speaks to you, and if not, there are a lot of things that are similar, so don't worry about that. But with this one in particular, what I like about it is that if you like this and you practice this, let's say twice a day, let's say you work up to something like 10 minutes at a time, then your brain gets used to what this is. And so when you're in that difficult, challenging interaction or the, stressful meeting or whatever, and you can take a breath, and if I can use you as an example, let's say you take that little phrase from the 23rd Psalm and you go, the Lord is my shepherd, right? It's that one? Yeah. If you're just going, the Lord is my shepherd. Now, you're saying that in your head, you're taking a couple of breaths. Nobody can see that that's what's happening, but that association that you've created will start turning things around. So your heart rate will already start to slow down. Your thoughts can slow down a little bit. You can take a step back and think about what you need to do. It's not a magic wand, but as I said, When we are triggered, when we are dysregulated, sometimes it's hard to find our way in. And something like a breath technique, just to slow it down, might be enough that now we can start doing the rest of the calmer skills. And to your point, I think that it probably would work for you if you're saying the whole 23rd Psalm, but you're in, I don't know, a crazy meeting or something, and you just have time to go, the Lord is my shepherd. I think that cueing will still work, especially if you're sharing, if you're pairing saying the prayer with the breath technique. Because the other thing that's happening is when we are saying that phrase and concentrating, focusing, as somebody said, we automatically slow that out breath down. It gets slower, it takes longer to breathe that breath out. And that engages the parasympathetic nervous system and the vagal nerve at the heart. It literally starts putting the brakes on the heart. So we tend to tell people to take a deep breath in, and that is kind of exactly the wrong thing to say. What we should be saying is stretch out that out breath. That engages the brakes on our nervous system. So this is just one version of this. There are a lot of things that are similar, but I like to give you guys things that you can do very portably in the moment. Nobody would even know you're doing it. And it's a way for you to regulate yourself. A, because you deserve that too. And B, because now you're in a better position to help someone else feel safe, connected, and in control. So often I experience when we're working with people, we think a lot about changing them, but often we have to start about changing where we are. So that's the calmer skills. And I guess I would just wrap up our time together with this. I've got all this stuff, but I always come back to this. I talked at the very beginning, and Kevin kind of started us off talking about trauma is the disease of not being able to be here and how it robs people of their lives. And I think that our willingness, and I'm going to use you guys right now specifically, your willingness to learn more, to work with trauma, to work with your own reactions to things, to develop the skills so that you're in a position to help someone else regulate around you. You give them what their brains need, because remember, the bad news is also the good news. So the good news is when they can interact with you and other people in that safe, connected way that helps them regain a sense of control over and over and over and over, that's what heals brains. And meds and therapy and behavior plans and stuff, that's all great tools, but it's the relationship and the interaction that heals traumatized brains. And so you are their best chance of getting that life and that person that they were meant to live and that they were meant to be back. So thank you. And thank you for your time today. We always enjoy hanging out with you guys.